I'm Anne Riddell, and this is Science and You, coming to you from the VA hospital in Manhattan. Pain, it's something we all feel at some point or another, but how we experience and manage pain can vary widely from person to person. We begin today with Dr. Max Gomez, who explores why some people seem to handle pain better than others, and what that has to do with the brain.
Believe it or not, pain is essential for survival. It tells us that the stove is hot, my leg is broken, I better get that pain in my stomach checked out. And another surprising thing about pain is that it doesn't really exist until the nerve signals from my bruised knee, for example, reach my brain, get processed and interpreted as pain. And since all of our brains are wired differently and we're constantly processing billions of bits of information, it's not surprising that we all have varying degrees of pain tolerance.
It can be jarring, it can be like an electrical shock. Even at night when I sleep, there are times when my knee will jerk because of the pain, because of the impulses from the pain.
After an ACL tear, 3 knee surgeries, and a torn meniscus, Nick Billy knows pain. So does Caitlin Fuchs.
At the times of going upstairs, it was extreme pain, like someone was stabbing me in the knees.
Caitlin's knee problems are similar to Nick's. So much cartilage damage she had to stop going to the gym, and playing with daughter Nora became more pain than fun.
I had like the knees of like a 90-year-old man was the first thing they said to me. Not a great thing to hear.
Yet both Caitlin and Nick were able to keep walking and working despite their pain, while others with similar knee problems would be incapacitated. Why is that?
Basic research now focusing on understanding these differences, why you and I perceive an oxyus, a painful stimulus, differently. And of course there's many factors that affect pain perception, such as stress, other diseases, drug history, other medications that the patient may be taking.
All of those factors vary from person to person, but they also vary from day to day, even hour to hour in the same person.
I think it depends on my mood, it depends on the environment, what's going on in my life.
Pain tolerance or the level of pain.
Absolutely. I think mental health plays a huge role in pain tolerance.
So how can it be that the same pain impulses coming from a bad knee, hip, or shoulder are perceived so differently, sometimes intolerable and at other times barely noticeable?
So pain can vary from between person and person and between a person within 2 different events. So what you'll have is a person sometimes might get stabbed with a needle and not feel it, and another time they'll feel it as exceptionally painful. You also have variations between people and people. One of the reasons is that you have hundreds of thousands of input going in both into the brain and from the body, from the brain, so the perception of pain changes. The other component is your state of mind also changes. So if you have a child that's under a car, you can potentially lift the car even though it's painful for it to you.
Brain function and wiring scans have also shown significant variability between these brain areas, again showing there really is a biological basis for the wide differences in pain perception and tolerance.
If I'm very busy and things are going well with my work, with my family, it's okay. I think when things start becoming very overwhelming, it can go downhill very quickly.
That pain is processed through so many pathways in the brain also explains why pain perception can be modified through various ways, including mood-altering drugs like antidepressants. It also explains why psychotherapy and counseling can also affect the perception of pain. Amazingly complex organ the brain is. For Science and You, I'm Dr. Max Gomez.
Periodic aches and pains are one thing. Chronic pain can be quite another, and treating it may require more than over-the-counter medication. Andrew Falzon explains.
There are many different ways to manage ongoing pain issues, from prescription medications to injection therapies. Consulting with a doctor who specializes in pain medicine is the first step.
But it's become an epidemic, an opioid epidemic, with people prescribing pain pills just to mask the cause of pain to millions and millions of people.
That epidemic is a big part of the reason why Dr. Houman Danesh tries to treat underlying causes of pain. As Director of Integrative Pain Management at Mount Sinai Hospital, he has a number of possible treatments to remedy the innumerable types of pain that can disrupt our everyday lives.
What do we treat in a typical pain practice? It's literally anything that hurts. It could be your head, it could be your knee, it could be a headache, it could be shooting pain into your leg, which is commonly termed sciatica. It could be pain in your chest that's not a heart attack. It could be pain in your lower back that can have different diagnoses and depending on what's going on there. So finding out what really is the cause and then coming up with a treatment plan for that.
And Dr. Danish has a number of tools and techniques at his disposal. Some have been around for years and others are cutting edge.
They run the gambit from epidural injections, joint injections in the spine, joint injections outside of the spine, physical therapy, proper physical therapy, certain medication management, creams, patches, and nerve blocks of all sorts.
And for Dr. Adam Bisaga, those new treatments are a welcome departure from the overuse and abuse of a group of very strong painkillers known as opioids.
So morphine, codeine, oxycodone, hydrocodone, hydromorphone, fentanyl.
And in his nearly 20 years as an addiction psychiatrist and researcher, Dr. Bisaga has seen opioid addiction numbers skyrocket. According to the National Institute on Drug Abuse, as of 2014, an estimated 2.1 million Americans have a substance abuse problem that's linked to prescription opioid medications. Researchers say it may be linked to the fact that between 1991 and 2010, the number of opioid prescriptions in the U.S. almost tripled, from 76 million per year to 219 million per year.
The good news is that any of those people can be helped. We have a very effective treatment. We just don't have enough people delivering this treatment, and that's one of the areas that we are working on.
The first stage of treatment lasts about 3 months under close medical supervision. Depending on the addiction severity, the patient could be monitored for up to 5 years. Research shows that the cold turkey and 12-step approaches are not as effective as addiction treatment that includes use of prescription medication.
It's very clear that treatment with medication is much more effective than treatment without the medication. Despite that, in the community, the primary mode that people are treated is still treatment without the medications.
At Mount Sinai, Dr. Danish is committed to matching the right patients with the right pain relief treatments so addiction never becomes an issue. On the day we visited, he was relieving knee pain by injecting a cocktail of amniotic membrane cells and platelet-rich plasma, 2 therapies combined into one treatment to alleviate pain, including arthritis of the knee.
Platelet-rich plasma, which is a part of regenerative medicine. So taking your own blood, spinning it down, and getting a very thin layer of platelets that have a lot of hormonal effects as well as local effects to help regenerate tissue.
Packed and preserved in dry ice, the amniotic membrane cells contain stem cells, and growth factors in those stem cells are believed to help regenerate damaged tissue and provide long-term pain relief, unlike steroid-based treatments, which are temporary and can weaken tendons in the long term. And unlike opiates, these therapies treat the underlying cause of pain and carry no known risk of addiction.
I think the general population thinks that you have pain, you take a pain pill. The side effects and the risks of taking prescription pain pills, such as opiates, have almost been masked or not talked about. And more we're learning how horrific of a problem we've caused.
But with more alternative pain treatments available and being developed, Dr. Danish is hopeful he can treat direct causes of pain and that others in the field will no longer rely on addictive opiates. I'm Andrew Falzon for Science and You.
People who suffer from migraines often deal with debilitating pain, pounding headaches that can make even simple tasks feel insurmountable. Magalie Laguerre-Wilkinson went to the Manhattan Headache Center to find out how patients can numb the pain with medical treatment.
One of the more frustrating pains in life are chronic migraines. Those who suffer from them describe challenges to their daily lives. But with new treatments out there, the results are promising.
At their worst, completely incapacitate me. There are varying degrees depending on the day. Sometimes it's like a big rubber band around the head. Other times it's like a lot of pressure, kind of like when you're in an airplane and you can't get your ears to pop, but just, kind of like a vice grip.
Samantha Cumley suffers from chronic migraines, something that she shares with 12% of the world population. And after trying different types of treatments, her primary care doctor recommended something called nerve block.
She thought that it might be beneficial because she thought that there was something going on with my neck and that could be aggravating the nerves. She tried it and it worked pretty well for me. I didn't have a headache for 6 weeks after that, which was pretty great that I could live a normal life, or relatively normal for that period of time. And then when I found Dr. Bronner, I was able to do them more regularly.
Dr. Susan Broner is the director of the Manhattan Headache Center and specializes in neurology and headaches.
So I'm actually injecting around the occipital nerve, the greater, lesser, and lesser occipital nerve. There are areas that one can palpate in the back of the head and feel the area where they're coursing through. And by injecting that, we're numbing the occipital nerve, and that's feeding back through channels, through neurons that reach the brainstem and help turn down or turn off a migraine attack.
So what makes nerve blocking treatment different from other treatments out there?
It's a combination of lidocaine and bupivacaine. I use that combination. Some physicians can add steroids sometimes for people with cluster headaches, but the combination of alone is those two anesthetic agents. They're similar to Novocaine. So a person will feel numb in the back of their head after the injections, and that wears off. The numbness wears off after a few hours.
There's no doubt that nerve blocking treatment is beneficial, but it's not a one-size-fits-all cure. Dr. Broner also stresses that migraines are in fact an invisible disease.
Meaning, a person is vulnerable to getting head pain that can be moderate or severe and usually associated with either light and sound sensitivity or nausea or even vomiting. And the attacks are very disabling. Either they wipe a person out completely or they affect the ability of the sufferer to function fully. And it's because of that disability that migraine is considered the 7th most disabling condition globally, and it's very common.
And though Dr. Broner sees migraine sufferers on a regular basis, she's encouraged with the possibilities of future treatments.
In terms of medications, people have been looking at this molecule called CGRP, or calcitonin gene-related peptide. It's a molecule that's a neuropeptide in the brain. It's very active in migraine and is pro-inflammatory. These new medications are looking to interfere with that CGRP and help reduce frequency. And then in terms of devices, there are devices on the market. One is called transcranial magnetic stimulation. It's a device that's about this big, and it's used to treat migraines acutely. So during an attack, particularly for people who have aura, it delivers a little bit of a magnetic stimulation to the back of the head at the onset of the aura attack and can interrupt and stop the migraine attack and stop the pain that comes afterwards.
While nerve blocking treatments and Botox may not be the best course of action for everyone, there are other treatments out there, so you ought to check with your physician. I'm Magalie Laguerre-Wilkinson for Science and You.
Walk down your drugstore aisle and you'll find plenty of over-the-counter pain relievers with specific instructions on how much to take. But some people don't want to use medication to combat their pain and instead turn to mindfulness and meditation. Here's the story from Donna Hanover.
Dr. Patricia Bloom of Mount Sinai Medical Center uses meditation when she teaches patients in her class mindfulness-based pain relief.
People who experience chronic pain over a long period of time, they get abnormal circuitry established in their brain. People get very anxious when they feel the pain come on. They right away catastrophize, oh, it's going to get worse and worse like it did last time. The slightest little stimulus can set off that perception of pain, and the perception is real. People are really experiencing pain. When you practice mindfulness, you're building up other circuitry in the brain. So you're strengthening other circuits that tend to diminish the activity of the pain circuit. And we can see that happening by looking at centers in the brain, with neural imaging.
What changes in the body during meditation?
The fight or flight system of the body is reduced, so blood pressure goes down. Also, the stress hormones that are released in the body, cortisol being one of the most important ones, the release of those hormones go down, reducing the muscle contraction part of the stress response, that helps to reduce pain. And the inflammatory system of the body, which now we understand is related to heart disease, brain disease, vascular disease, is also diminished.
Dr. Bloom says some people use the term mindfulness to avoid any religious tone of meditation, although many use the terms interchangeably. Her classes are held at Mount Sinai's Martha Stewart Living Center and occasionally here at the Zen Center in New York. She says Professor John Kabat-Zinn is credited with bringing meditation into the mainstream at the University of Massachusetts Medical School in the 1970s to help people deal with stress and pain.
Some people who are skeptical of mindfulness or meditation might say something along the lines, well, I see people practicing it and they seem kind of zoned out.
People have all kinds of ideas about, oh, you're emptying your brain. In fact, it's actually the opposite. It's paying a lot of attention to what is in the mind right in this moment. So the breath is a common practice, paying attention to our breath. That's a mindfulness practice.
Another technique Dr. Bloom uses is open focus.
Open focus is a technique that was developed by Dr. Les Femi in Princeton, New Jersey. It's been his lifelong career. He would call it a brain exercise rather than a meditation. The training is to widen the scope of attention, very, very broad scope of attention, in a way that he has shown with brainwave studies and with people's subjective reports seems to make pain go away, or at least get much, much less in the moment that they're practicing that technique.
These techniques offer hope that use of pain medications can be reduced.
The National Institute of Health has made pain a high priority because it's an unsolved problem in conventional medicine.
Or is there intention to try to reduce drug use?
Certainly.
That drug addiction?
Yeah, absolutely. Mm-hmm. There's a big worry about people on opioid medications getting addicted. People who practice these techniques often reduce their use of pain medications.
I've had back problems since I was very young, and I have a curvature of the spine, so that's where some of it comes from. And meditation and open focus has allowed me to really get control over it. So especially if I can do it early, like when I wake up, that can make the whole difference for the day.
Really?
Yeah.
Better than taking pain medication?
Oh, absolutely.
I have severe pain in my ankle due to arthritis. I experience the pain during mindfulness, but then it dissolves.
Does it stay dissolved when you leave the meditation?
I would say it's lessened. It will come up again, but less so. So it's very helpful, extremely helpful.
Dr. Bloom says even when patients still have pain, mindfulness often helps them cope.
They're more functional. They say that the pain doesn't bother them as much.
I have fibromyalgia, which is an extreme neurological reaction to pain in your body, anywhere. And meditation seems to make it easier to deal with. It periodically helps me get rid of it, but even when I am in pain, I am able to manage and sort of isolate it.
Let me say that it is work, by the way. You have to do this for 20 or I would have to do it for 20 minutes or half an hour, but it's so much worth it because you bring the pain down.
Those who've had success at reducing pain with mindfulness and meditation are very grateful, and they welcome others to give it a try. I'm Donna Hanover for Science and You.
Imagine feeling pain in a limb you no longer have. Many people who've been through amputations cope with exactly that. It's called phantom pain, and the discomfort is very real. A split-second decision 3 years ago changed veteran Pamela Winfield's life forever. As she describes it, she heard a struggle in her apartment building, first upstairs, then outside her door. Next, she jumped in to help a woman she didn't know, whose attacker was armed with a sword.
So I just kept wailing my hands and my legs as much as I could, and he just kept slicing me over and over and over.
How did you survive that situation? You told me before that your sort of training kicked in?
Yes, ma'am. My military instincts kicked in after he sliced me on my left leg. and I got on my elbows and I pushed my entire body back to the apartment door, and I got in and I pushed the door closed with my left leg.
Now at this point, you're obviously incredibly wounded. You end up in the hospital. You wake up in the ICU.
I wake up and my hand is no longer there.
Any pain along there?
No.
Okay.
With regular care and the comfort of her support dog Hummer, Pamela continues to rebuild and relearn, but it's a difficult road. And like many amputees, she's coping with what's known as phantom pain. Dr. Jason Sieferman is a pain management specialist at VA New York Harbor Healthcare System.
You have a sensation that's uncomfortable in the structure that's no longer there.
How is that possible?
Well, these nerves that go from the brain to the hand, for example, the brain knows that that nerve goes to the hand. If that nerve is cut any place along that path, the brain still thinks it's the hand signaling that nerve.
The perception in my mind is that my hand is still there. This is a thumbs up. Right now my thumb is up, and that's what it feels like.
The power of the brain.
The power of the brain tells me that thumb is up right there.
Dr. Sieferman explains amputees may have 3 different categories of sensation: residual limb pain, pain in the remaining portion of the limb; phantom limb sensation, feeling the limb that is no longer there; and phantom limb pain, which is actual discomfort, for example, a cold, cramping feeling. Despite the name, phantom pain, this is very, very real.
Oh, absolutely. It's not the pain that's the phantom, it's where you're feeling it that's the phantom. So with Pamela, for example, she experiences phantom pain in the palm that's no longer there, and a trigger for her is moving the wrist, rotating the wrist.
What do I feel? Tingling. I feel tingling and like movement.
Was it like
discomfort.
pins and needles?
It's like pins and needles in the palm of my hand.
Dr. Sieferman says treatment for phantom pain varies and can include medication, injections, cognitive behavioral therapy, physical approaches like prosthetics and electrical stimulation, and imagery approaches. For example, a mirror box, which can help the patient envision, control, and relax the phantom limb by placing the functional limb in a box outfitted with mirrors.
So it's tricky, and every patient is individual, and what they experience, what triggers their pain is individual. So you really have to examine that patient, determine exactly what's going on. Typically, it gets better with time, and we know that it gets better with a good prosthetic.
Pamela says using prosthetics along with other therapies has helped her, both physically and emotionally.
Nobody knows that your hand is not there, because again, when you go in public, people are going to focus on your limb loss. All right. Oh, that's such a sweet baby. That's a sweet baby.
And then there is this 5-pound bundle of love.
He licks my limbs. He licks my tears away. He makes me laugh. And he's just, he's just the best comforter anybody could have.
It's made a huge difference in your life?
He's made a big difference in my life because he didn't judge me because I didn't have a hand.
Despite what she's suffered, Pamela says she never asks why me or regrets stepping in to help a stranger. Self-pity is not an option.
I would do it again with one hand. That was somebody's mother, daughter, sister, grandmother, and I couldn't have closed the door and not helped her.
Finally today, a fascinating look at the legal definition of pain and how developments in brain imaging technology are affecting personal injury cases. Beth Kovetz has a follow-up to our story on the proof of pain.
Michael, what's the legal definition of pain?
I think the legal definition of pain is the common sense definition of pain. It's what hurts.
3 years ago, we talked about the use of the fMRI in relation to pain.
3 years ago, there was already a robust scientific literature showing patterns of brain activation that were strongly correlated with chronic pain. And there was also, in other types of imaging, significant proof that pain is not just a feeling, but it's a corrosive disease which atrophies parts of the brain and damages connections within the brain and compromising the brain's ability to communicate with itself.
And what's changed in 3 years? What's happening now?
Well, I think the analysis has advanced a lot, and they've been able to identify what they using what they call biomarkers, certain specific patterns in the brain that are associated with certain types of pain, And they've also been able to much more strongly substantiate brain patterns associated with chronic pain. They've been also not just able to show anatomical consequences of chronic pain, but also correlate the functional ramifications of those anatomical consequences, the functional changes that occur when the brain is atrophied or connections are damaged or changed as a result of chronic pain in terms of changes in memory, changes in emotion, things like that. I think the best example is the O.J. Simpson case. When the O.J. Simpson case was being tried, the prosecution presented O.J. Simpson as a monster, and the defense was that he didn't do it. In 2015, there might be a very different narrative. Rather than him being perceived as a monster, O.J. Simpson might have been perceived, assuming he committed those crimes, as a victim perhaps of too many concussions, which dysregulated his brain. And so a defense attorney in 2015 might pursue brain imaging to show what was going on in O.J. Simpson's brain, and that tells a very different story and removes that story from the morality tale that the prosecution was pursuing back those years ago. 10 years ago, there was no, if little, recognition that pain could atrophy the brain, or that pain could degrade or change the connections between different parts of the brain.
Are there hurdles to overcome?
Every neuroscience advance that I see, and my practice concentrates on the interface between neuroscience and law, every such advance is met with tremendous resistance. First of all, when you're talking about an objective proof of pain, you're talking about information that can have tremendous financial consequences. Most cases in personal injury, for instance, involve a dispute regarding either the existence or the severity of pain. There's hundreds of millions, maybe billions of dollars at stake in terms of what this information can ultimately signify. And whenever there's great financial exposures, you can expect there'll be tremendous resistance. Also, the understandings that the neuroscientists provide are very different than the training and funded knowledge that physicians have. And since physicians are seen culturally and by judges as preeminent in matters concerning the body, there's tremendous skepticism and resistance when neuroscientists who are PhDs, for the most part, not MDs, are basically contradicting what physicians are saying, and that's very disruptive. Whatever the institution is, and law is one of the most major institutions, but any institution that's subject to that type of disruption is going to respond with skepticism and resistance. There are tremendous advances in imaging neuroscience and cognitive neuroscience in terms of showing this correlation. The fact that pain is a brain phenomenon, the fact that pain damages the brain in neuroscience is now irrefutable. There's no turning back.
Thanks so much for spending time with us. This has been Lisa Beth Kovetz for Science and You.
That's our show for today. Next month, an end-of-year special. A look back at some of our most interesting stories from 2015. I'm Anne Riddell. Thanks for joining us for Science and You.